There are two types of complex regional pain syndromes. Over distraction with external fixator is a cause of a complex sympathetic dystrophy. Am I right? So be very careful if you are using a external fixator not to over distract. You might see the excess beautifully, but you'll also see not a very beautiful results, and therefore let your distractor collapse so that the distance between your distal radius and the scaphoid is reasonable within the tolerance. A malunited fracture will give you better results than a complex sympathetic dystrophy, which will affect adversely everything else also, and therefore problem is less if the fracture is collapsed a little bit, but distraction and over distraction will give you more problems. Yeah. Now, what do you think about this? In the back of your mind, I am not putting up this as a question. You think there's a sympathetic dystrophy or this is a stiff hand? Let's talk about this. Like compartment syndrome, the pain is out of proportion. It is swollen, it is shining, and the movements are grossly restricted. Now, it is with a nerve injury or without a nerve injury. When it is without a nerve injury, we call it grade type 1. When it is with a nerve injury, it's called as a type 2. And therefore the idea should be always identify if there is a known or unknown nerve affection as well. Nerve affection can be median nerve, ulnar nerve and radial nerve. 3 nerves only. So patient not necessarily would be saying I have a tingling and numbness. It is your job at this point when the patient is having a stiffness to start doing your Tinel sign, Phelan test, reverse Phelan test, all tests possible to see if there is a underlying radial nerve, median nerve or ulnar nerve affection. There is no definitive test to see whether it's a CRPS or no CRPS. But one thing for sure is in all complex regional pain syndromes, there is a preceding trauma. There is an abnormal host response to trauma. It may not affect a nerve territory. Nerve territory, as I said, median nerve, ulnar nerve and radial nerve. But it's the glove and stocking type. The whole area is affected when you have a CRPS. There is no test to confirm it and there is no instrument to prove a diagnosis. So type 1, as I said, is without a nerve. Type 2 is with a nerve. Suppose the left hand is affected, the patient moves the right hand. And when the patient is moving the right hand, he is seeing the image of the right hand which is overlying the hidden left hand. So mirror visual feedback is helpful. So patient moves the unaffected right hand and he thinks it is the left hand which is moving. So this visual feedback is also useful. It is worth a try, simple method without any specific expenditure. And he wrote in the editorial, I have a dream. Reflex sympathetic dystrophy type 2, type 1. Type 2 is with the nerve. Type 1 is without the nerve. Does not exist. Our work as scientists is to challenge unproven knowledge. ये बॉस मैं ही दुनिया में सबसे होशियार आदमी हूँ. मैंने बोला नहीं मारे तो I am going to kill you. No, this is stupidity. This is not exchange of knowledge and advancing yourself. Our work as scientists to challenge unproven knowledge. CRPS 1 offers an unparalleled dustbin where all difficult problems. If my patient is not doing well, I tell the patient you are useless. You don't follow my instruction. No, I did a bad fixation. I am not willing to accept it. I am blaming it on the patient. I am blaming it on the physician. I am blaming it on the physiotherapist. The problem was with my bad fixation. When I was making a suturing the tendon, I sutured the nerve with the tendon, and that's what is leading to insensate hand. It's the result of poor surgery, and therefore, and then I say blame physiotherapist, blame the physician, blame the patient. The article further says disease has to be based. Disease is based. Diagnosis of CRPS1 is based purely on subjective diagnostic criteria, and there is no test to prove it. Are we not looking at something? And that is identify if the patient has a subclinical median nerve, radial nerve, ulnar nerve compression. The article further says, I do not see this condition, that is CRPS1, that is without nerve affection, in my patient, in his patients. And if we don't see, and if you are making a mistake, we find out an easy way out and we call it CRPS1. They said, what about unstable fracture? There are no signs and symptoms. and what is called as a fracture disease, and we call this as CRPS. Coming back to something, he said, identify an underlying nerve pathology like external fixator. You are distracting the median nerve unnecessarily and precipitating the symptoms. And therefore, either you reduce it and see if the median nerve is getting stretched, or there is another cause of nerve compression, glomus tumor, radial nerve, typical nerves. So identify nerves which are likely to be affected, which may have been affected but we have missed it. The moment you identify an underlying nerve disease, you attack that nerve by decompressing this nerve, and the symptoms of CRPS will disappear. So the moment you have a patient with CRPS, what you'll do? Radial nerve. See if the patient has motor nerve radial tunnel syndrome. You percuss on the median nerve, you do a Fallon test, you do a Durkin test, ulnar nerve passive elbow flexion test, pressure on the intermuscular septum where the lateral and between the brachioradial and by brachioradialis and ECRL, and see if the radial nerve is compressed. So identify one of the patient has thoracic outlet syndrome. See this and ask them to move this, take the shoulders back, and see if you can identify one of these things. And if this can be ruled out, sure enough, probably you, and surgically if need be, you decompress them, and it's very likely the CRPS will disappear. In fact, only recently I saw one of his articles. He has presented a series. I did a subsequent median nerve decompression, and CRPS part 2 type 2 symptoms disappeared. So coming back to gist of this article, CRPS 1 without nerve, CRPS 2 nerve affection. If you are having a patient who suspected CRPS, correct the posture. Wrist flex, bring it to extension. Edematous, elevate it. Move the shoulder. Identify the nerve. If you identified the nerve, decompress the nerve, and symptoms will vanish. CRPS is still not moving. Identify whether that is a stiff hand or CRPS itself. If it is stiff hand, use any of these mobilization devices, move the fingers, and sure enough, you will be much better off. Elevate the part, insist the elevation, strengthen the scapular muscles, and probably the symptoms will vanish. So this is what it was saying about CRPS.